There's no better feeling than a personal win, and the State Farm Personal Price Plan can help you do just that. Talk to a State Farm agent today to learn how you can bundle and save with the Personal Price Plan. Like a good neighbor, State Farm is there. Prices are based on rating plans that vary by state. Coverage options are selected by the customer. Availability, amount of discounts and savings, and eligibility vary by state.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in school and at the bedside. Before we hop into today's topic, let's take a quick minute for our listener shout out. This one goes out to Saber, who says, "Thanks so much for what you do. I have been listening to your podcast during my first semester in nursing school. I listened to you almost every day while out walking, and when I added study sesh, game changer. I actually heard your voice a few times while taking different tests, and of course, that voice led me to the right answer. I always said a quick, 'Thanks, Nurse Mo,' during those moments and smiled. I finished my first semester with an A, and you were there with me through all of it, from lecture to studying to clinicals. I couldn't be happier, and I've shared your podcast with fellow students to spread the love." Saber, thank you so much for sharing the podcast with others and sharing your experience with the podcast and study sesh, and how both of those have helped you thrive in nursing school and do well on your exams. I'm so proud of you. All right, so today's topic is Myxedema Coma. So Myxedema Coma is a complication of long-term, untreated, or very poorly controlled hypothyroidism that causes an inability for the body to maintain homeostasis. Now, if Myxedema Coma is not treated, it can lead to respiratory failure. It can lead to GI bleeding. We'll talk about why that happens in a moment. Myocardial infarction is another somewhat common complication, sepsis, and even death. So let's now talk through Myxedema Coma physiology, and then we'll get into it using the Straight A Nursing LATTE method. So as you probably remember from your anatomy and physiology class, the thyroid gland produces two very important hormones, T3 and T4. T3 is triiodothyronine, and T4 is thyroxine. I'll just call them T3 and T4 because that first one is kind of hard to say. So of these two hormones, T3 is the most potent, and most of the body's T4 is actually converted into T3 in the tissues. Thyroid hormones are so important for body function. They influence every cell in the body and have a significant influence on most of the body's functions, which is why a patient in Myxedema Coma can have such a broad range of presenting symptoms. Myxedema Coma is an extreme form of hypothyroidism and can occur without precipitating factors or when the body's homeostatic mechanisms are overwhelmed by stressors such as infection, hypothermia, hypoglycemia, surgery, and even some medications. So some medications that have been known to cause hypothyroidism and Myxedema Coma are amiodarone, lithium, and phenytoin. All right, now that you've got a baseline understanding of Myxedema Coma, let's dive into it using the Straight A Nursing LATTE method. If this is your first time hearing about the LATTE method, it's very simple. It's a streamlined, focused framework so that you can just zero in on the key things that you, as a nurse or a nursing student, need to know. And the first letter is an L, and that stands for look. How does the patient look? In other words, what are the signs and symptoms of Myxedema Coma? So the manifestations of this condition are pretty widespread, which you'll see in just a moment, simply because thyroid hormone influences most of the body's functions. So one way that you'll see this manifest in your patient is with temperature dysregulation. Hypothermia is a common clinical manifestation of myxedema coma, with temperatures typically measuring below 35.5 degrees Celsius or 95.9 degrees Fahrenheit. So pretty darn cold. The lower the patient's body temperature, the worse the prognosis. And then another manifestation would be neurologically. Neurological manifestations include lethargy, confusion, decrease in intellectual function, decreased deep tendon reflexes. Psychosis can even occur, and so can coma, which makes sense, right? It's called myxedema coma. Next are respiratory manifestations. Now, a patient with myxedema coma will have diaphragmatic weakness. And because of that, a decreased ventilatory response to low oxygen levels or high carbon dioxide levels. So, what you will observe in a patient is hypoventilation. Those breaths are going to be shallow and they're going to be slow. You can also have edema of the tongue or pharynx or both, which can cause airway obstruction, which further impedes proper respiratory function. Now, hypercapnia, or that elevated CO2 or carbon dioxide level, is thought to be one of the main causes of coma in these patients. And then there are cardiac manifestations. Initially, the body is going to attempt to compensate for that hypoxia and that hypothermia through peripheral vasoconstriction and shunting of blood toward the vital organs. And what this causes is an elevated diastolic blood pressure. So if you have a patient, you think they're looking kind of myxedema coma-ish, and they have a diastolic blood pressure that is elevated, that can be another piece of evidence that this is what's going on with your patient. However, as these compensatory mechanisms fail, and they will eventually fail, the patient then becomes hypotensive. So then the patient's hemodynamic stability is even further reduced due to bradycardia, which is also present in myxedema coma, and decreased cardiac output. Other cardiac manifestations include heart blocks, bundle branch blocks, a low voltage EKG tracing. The patient could have a prolonged QT interval, which is very, very dangerous. It can lead to some pretty scary cardiac arrhythmias like torsades de Pointes and ventricular fibrillation, and it can even cause cardiac arrest and shock. So those are some pretty wide-ranging and scary cardiac manifestations of myxedema coma. Next up, we have hematologic malfunction. In myxedema coma, patients have decreased clotting factors. So what do you think this does for their bleeding risk? It's going to drastically increase their risk for bleeding. And then there's immunologic dysfunction. Myxedema coma can impair the body's ability to respond to infection due to basically its wide-ranging effect on all body systems. And then there's gastrointestinal effects. Common GI manifestations include nausea and vomiting, ileus, abdominal distension, megacolon, which comes with that ileus, abdominal pain, constipation, and a lack of appetite. In addition, GI bleeds can occur due to those hematologic complications or that lack of clotting factors. And as I mentioned at the beginning of this episode, GI bleed or GI hemorrhage is a cause of death in myxedema coma. And then there are renal and electrolyte problems. Patients with myxedema coma typically have low GFR, urinary retention, and hyponatremia. So the hyponatremia is due to decreased excretion of free water, secondary to increased antidiuretic hormone and that low GFR. That hyponatremia, which is a low sodium level, is another leading cause of altered mental status and coma in these patients. And then the last one is just general physical appearance things. The face of a patient with myxedema coma may appear puffy with periorbital edema. They could have ptosis, which is a drooping eyelid. They could also have an enlarged tongue and very thin hair. The patient may also have dry skin, non-pitting edema of the lower extremities, and in some cases, they could have a goiter. Now, let's say you're checking out your patient and you notice a scar on their neck. This could indicate a prior thyroidectomy, which is removal of the thyroid gland, which would 100% put the patient at high risk for hypothyroidism and subsequent myxedema coma, especially if they're not taking their hormone replacement therapy or not taking an adequate dose. The key things to know when you are looking at a patient with myxedema coma is the most common signs and symptoms are going to be that altered level of consciousness, hypothermia, hypotension, bradycardia, and hypoventilation. So again, that was altered level of consciousness, hypothermia, hypotension, bradycardia, and hypoventilation. And what do all these things have in common that I've talked about? It's kind of like everything's slowing down. Nothing is working up to its capacity. So when you think hypothyroidism and myxedema coma, think of things slowing down or being less than what they should be. All right, let's move on to the next letter in the LATTE method, which is an A, and that is assess. How do you assess a patient with myxedema coma? Now, because myxedema coma can manifest in so many ways and have such a wide range of complications, assessments will also be very generalized. Key things to assess include, first off, let's get a full set of vital signs on this patient. The patient is likely to have that low respiratory rate and be hypothermic, hypotensive, and bradycardic. Next, we want to assess our mental status and our level of consciousness. Again, definitely going to be altered here in some way. Maybe it's just lethargy. Maybe it's total and complete confusion. Maybe they're unresponsive and in a coma. We're also wanting to assess for edema of the tongue and the pharynx. This is very, very important from a safety standpoint. When anything around the face, the neck is swollen like that, I want you to think airway, airway, airway. Your patient is at high risk for airway obstruction and respiratory failure. We're also going to monitor the patient for any EKG changes and any cardiac arrhythmias. They're definitely going to be on continuous monitoring. We want to listen to those vowel sounds, which will be absent in the case of an ileus. And we'll measure urine output, which can be decreased due to an increase in antidiuretic hormone and that low blood flow to the kidneys, that low GFR. We'll definitely monitor for signs of bleeding, especially GI bleeding, which I mentioned earlier is definitely a very serious complication of myxedema coma. And we want to look for signs of infection, which can precipitate or complicate myxedema coma. This could be things like cloudy urine, which would be suspicious for a UTI. Maybe the patient has a cough with thick, gloppy sputum. That would be suspicious for pneumonia. Or maybe they have a wound with purulent drainage. So looking for signs of infection. While I'm loving this cooler weather, the shorter days honestly feel like I've got to do the same amount of work in a lot less time. And one way I found to save time is with Factor's no prep, no mess meals. From breakfast to dinner and anything in between, Factor has you covered with 35 different delicious meals to choose from every week and over 60 additional convenience options you can add to your box. I'm a big fan of the smoothies, and I love how Factor's nutritious meals help me power through my days so I can get everything done before the sun goes down and the pajamas come out. Another thing I love about Factor, especially as it gets cooler out, is that they have guilt-free comfort foods that warm me up, like sweet potato and chickpea curry and home-style chicken and gravy. Plus, Factor is cheaper than takeout or dining out, so I can put that extra cash towards holiday shopping. So let Factor take shopping, prepping, cooking, and cleaning up off your daily list of things to do. Head to factormeals.com/nursemo50 and use code nursemo50 to get 50% off your first box and 20% off your next month. That's code nursemo50 at factormeals.com/nursemo50 to get 50% off your first box plus 20% off your next month while your subscription is active. So far, we've been through the first two letters in the LATTE method, L and A, which stand for look and assess. Next is a letter T, and that stands for tests. So what tests would you expect to be utilized to evaluate a patient with either confirmed or suspected Myxedema Coma? So the main one is going to be thyroid hormone. We're going to get some thyroid hormone labs. TSH will be elevated, while T4, free T4, and free T3 will be low or undetectable. And then there's CBC. The patient may be anemic and could also have a low white blood cell count. Also looking at blood glucose levels. Hypoglycemia can occur due to that decreased metabolism. We're looking at sodium levels as well. Remember, hyponatremia is very common and can cause some pretty serious neurological deficits. We want to 100% check that our patient is not hyponatremic. If they are, we're going to be addressing that, and we'll talk about treatments in just a moment. A cortisol level may be drawn. Hypothyroidism can mask adrenal insufficiency. So let's get a cortisol level on our patient. Creatinine is another one related to renal function. It's very likely to be elevated in that impaired renal function. And an ABG, which is an arterial blood gas. This could reveal hypoxia, hypercapnia, and respiratory acidosis. A lumbar puncture could be done. Usually it's done to rule out other causes for the neurological deterioration. When it is done on a patient with Myxedema Coma, it typically shows a high protein count due to increased permeability of the meninges and decreased metabolism overall, as well as elevated pressures. And then an EKG. We want to have our patient on continuous EKG monitoring because we want to catch any arrhythmias or significant bradycardia as they occur, but the doctor may also order a 12-lead EKG, especially if you're noticing something abnormal on your continuous monitor. So tests again include thyroid hormone, that's the big one, CBC, glucose, sodium, cortisol, creatinine, an ABG, a lumbar puncture, and again, that EKG. So the next letter in the LATTE method is another T, and this one stands for treatments. Now, patients with Myxedema Coma are very seriously ill. They will require ICU care and continuous monitoring for complications, and even complications that can occur as we are treating them. So we want to make sure we're keeping a very close eye on these patients. Now, the mainstay of treatment is thyroid hormone replacement in the form of IV, T4, and T3. Now, some of the references I found suggested just giving T4, but one of the references that I use that I trust the most is Up to Date because it's up to date. And that recommendation was for both T4 and T3. So levothyroxine, which goes by the brand name Synthroid often, is the synthetic form of T4. And remember, T4 must be converted into T3 in the body. So when we have a patient with Myxedema Coma, they're going to get a high dose of levothyroxine initially, and that can range from about 200 to 400 micrograms. And we give this as a slow IV bolus, followed by daily doses of levothyroxine in the 50 to 100 microgram range until that patient is able to take PO medication. Then we can transition to PO medication. So I've had a patient in Myxedema Coma before in the ICU, and yes, they presented with those exact symptoms: hypoventilation, hypothermia, bradycardia, hypotension, all of that. And I remember getting a bag of levothyroxine and also of this T3 in a tiny little bag, like as an IV piggyback, and hanging that to run in slowly. And I had never done that before because I had always only ever given levothyroxine as an IV push, like a dose of 50 micrograms, for example, for your standard patient with hypothyroidism. But instead, this was a bigger dose given as an IV infusion or that slow IV bolus. All right, so that was T4, levothyroxine. And then the other medication is liothyronine, and this is T3. And it is given concurrently with that T4. Like I said, up to date, which is a very, very, up to date reference recommends giving both of these medications. Though you may see, again, some cases where only T4 is administered. Remember, T4 has to be converted into T3 in the body. And in hypothyroidism, that conversion can be impaired. Plus, T3 has greater biologic activity and more rapid onset than T4. It's also, though, very important to note that the dose of liothyronine is not that big. We actually don't want to give high doses of T3. They should be avoided. A typical initial dose of liothyronine or T3 is 5 to 20 micrograms, and then follow-up doses range from 2.5 to 10 micrograms every 8 hours until the condition improves, and then the patient will just be on the T4 medication. Now, another medication that you likely will see used are glucocorticoids, and the reason for this is that the administration of thyroid hormone increases cortisol metabolism, which could be very devastating for a patient with adrenal insufficiency. So for this reason, glucocorticoids, which commonly is hydrocortisone, are given prior to that thyroid hormone that I just mentioned. Even though we don't have the cortisol level back yet from our labs, we go ahead and give this. And then if the patient doesn't need it, we can stop it or decrease it once we have their cortisol level from the lab. So to recap, the mainstay of treatment is thyroid hormone replacement with T4 and T3. That T4 dose is going to be higher, and the T3 is likely only going to be used until the patient starts to stabilize and improve. And then glucocorticoids, likely in the form of hydrocortisone, just because we are going to increase cortisol metabolism when we give that thyroid hormone, and we don't want a patient in adrenal insufficiency to go into adrenal crisis. We also want to support our patients by addressing and preventing complications. So there are quite a few supportive therapies for a patient with myxedema coma. So one of those is warming. Remember, these patients are hypothermic. Patients with myxedema coma are passively and slowly rewarmed using something simple like warming blankets. If we try to increase the temperature too quickly, this causes vasodilation. Our patient's already hypotensive, so what do you think systemic vasodilation is going to do? It would worsen that hypotension. So we're going to passively rewarm them with warming blankets. The patient may also need mechanical ventilation. And this would be for severe hypoventilation, for airway obstruction, for a patient that's gone into respiratory failure, or maybe just for airway maintenance or maintaining airway patency in a patient who's in a coma. And then we also will replace fluids and electrolytes as needed. We would give fluids. The patient's going to be hypotensive. We can give fluids to help with that. The fluids are going to have sodium in them, which would help correct that hyponatremia. And if there were any other electrolyte abnormalities because of that impaired renal function, we could address those as well. And then dextrose. Remember, hypoglycemia is common in myxedema coma. We can treat that with some IV dextrose. We also want to take a moment and see if we can address the underlying cause. A common underlying cause or precipitating factor that could kick someone into this severe form of hypothyroidism is infection. So you may see antibiotics started while infection is investigated. And then vasopressors. Now, if fluids are not effective in treating hypotension, and you should, in most cases, see fluids gone to first, then vasopressors could be utilized until that thyroid hormone has had time to take effect. The main treatments for hypotension and myxedema coma are fluids and thyroid hormone. But if the thyroid hormone has taken a while, you could see vasopressors utilized short term. However, note that this can increase the risk of cardiac arrhythmias, so be very, very vigilant that you're monitoring your patient very closely. And then that last letter in the LATTE method is an E, and that stands for education, because as nurses, we are always educating our patients. So the main thing to teach your patient about myxedema coma is prevention of myxedema coma. This is generally pretty easy to do. It's generally through adherence to thyroid hormone supplementation and also in knowing how to recognize the signs of hypothyroidism, which could indicate they need their dose adjusted, or maybe there's something else going on that's limiting their body's ability to maintain homeostasis. They should also have their thyroid function monitored regularly with lab tests such as their TSH. Even if the patient doesn't have hypothyroidism, let's say they're taking amiodarone, and that's a new medication for them. You want to teach them, you need to have your thyroid function tested. If they're taking lithium, same thing. So there you have it, your quick overview to myxedema coma, not a super common condition, but it can happen and it can be absolutely devastating for your patient, as you've learned from listening to this episode. Thank you so much for sharing your precious free time with me, or your commuting time, or your walking the dog time. It means the world to me. I look forward to sharing some time with you again next week. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
From the creators of the popular science show with millions of YouTube subscribers comes the Minute Earth podcast. Every episode of the show dives deep into a science question you might not even know you had. But once you hear the answer, you'll want to share it with everyone you know. Why do rivers curve? Why did the T-Rex have such tiny arms? And why do so many more kids need glasses now than they used to? Spoiler alert, it isn't screen time. Our team of scientists digs into the research and breaks it down into a short, entertaining explanation, jam-packed with science facts and terrible puns. Subscribe to Minute Earth wherever you like to listen.